So, as an introduction, I'll review some of the multitude of etiologies which may be responsible for failure fixation above the proximal femur. I'll review some of the basic evaluation which is necessary in order to discern which of these etiologies is most likely responsible for failure after femur fixation. And then, more importantly, I'll discuss how these etiologies pertain to whether or not an arthroplasty is indicated, whether or not it's contraindicated, and in which circumstances arthroplasty may be a viable alternative even to acute internal fixation. And then lastly, I'll talk about some of the basic principles which are common to reconstruction above the hip for any total hip conversion after failed femoral fixation. And Dr. Sassoon and I will talk in a little bit more detail about these specific etiologies and specific failure patterns about the femoral neck, intertrochanteric fractures, and acetabular fractures. Hopefully we'll have some time to discuss specific management principles, some current controversies which affect all of these specific problems, and then hopefully provide some evidence-based recommendations after that, leaving some time for discussions and questions at the end. So ultimately, the preoperative evaluation begins with asking, why did the fixation fail? We know that in total arthroplasty literature, particularly revision literature, understanding the cause of failure is the most important independent predictive value of whether or not post-operative reconstruction is going to be successful. Obviously, if you don't understand why something failed, it's unlikely you'll be able to provide a reasonable solution which will be successful. We know that there are some common reasons that internal fixation fails. Certainly, the etiologies can broadly be described as biological, mechanical, or septic. We know that significant overlap certainly exists amongst these three etiologies, and it's not uncommon for fixation in the same person that failed for each of these problems individually or cumulatively would be responsible for ultimate failure. For biological reasons, we know that there are both patient-dependent and patient-independent factors. For both the trauma literature and arthroplasty literature, this has been extensively studied. We know there's significant overlap between the pre-existing risk factors, which may predispose somebody to infection. Nutritional factors, certainly in the polytraumatized patient in a catabolic state, may predispose somebody to delayed union or non-union. We know in the arthroplasty literature, multiple independent risk factors, obesity, preoperative anemia, low white counts, albumins, etc., are independently associated with poor outcomes post-operatively, particularly as they pertain to surgical site infection. Smoking, diabetes, anti-inflammatory use in the trauma literature, basic science literature, some clinical work demonstrates an increased likelihood of infection and certainly a non-union. In the arthroplasty literature, we know that this can result in failure both from septic and aseptic loosening. Metabolic reasons are very important. Certainly in the trauma literature, we know this. In the arthroplasty literature, particularly as it pertains to osteoporosis, has significant implications on how these patients may be managed. Osteoporosis in of itself is certainly a risk factor for fracture or periprosthetic fracture. So often these patients have already demonstrated that the bone is abnormal, and the likelihood of obtaining mechanical fixation with press fit components or cementless fixation is often unreliable. Patient-independent factors, obviously for trauma, location of fracture, present comminution, soft tissue stripping are all important factors and are independently associated with the likelihood of non-union. In the arthroplasty literature, this is equally important as the viability of the blood supply to the bone, particularly the endosteal blood supply, is critically important in order to reliably achieve osteointegration or definitive mechanical fixation. So many of these patients who may undergo an open fracture also may not be suitable candidates for cementless fixation. You may look to alternatives such as cemented fixation in order to provide them with relief. So the preoperative evaluation, osteonecrosis, particularly as it pertains to the femoral head, we know is independently associated or reliable on the integrity of the deep branch of the medial femoral circumflex artery. We know that this is highly reliant on the location of the fracture. Certainly subtapetal fractures, depending on the degree of displacement, have a much higher likelihood of osteonecrosis in comparison to intertrochanteric fractures. The degree of comminution is an independent risk factor for failure after internal fixation, particularly posterior medial comminution as it pertains to the proximity of the deep branch of the MFCA, as well as the likelihood of being able to achieve rigid internal fixation in the context of these difficult fractures. We know the fracture reduction, or the accuracy of the fracture reduction, is very important. particularly as it pertains to malrotation or varus malunion, is independently associated with failure of these fractures. And then timing, which is more controversial in terms of whether or not acute versus late fixation ultimately changes the natural history of osteonecrosis in these patients. So why is this important in terms of how it pertains to arthroplasty? It's important because osteonecrosis should be explainable. Regardless of the type of fracture, osteonecrosis should have one of these pre-existing risk factors in order to explain it. We know that osteomyelitis may in itself cause an environment where osteonecrosis is possible. It can result in intraosseous pressures, which can compress the microcirculation of the femoral head and cause osteonecrosis. We know that total hip arthroplasty for osteonecrosis has a higher incidence of periprosthetic fracture in comparison to total hip arthroplasty for primary degenerative arthritis. So that may be explained by multiple factors, but certainly one of those may be insidious osteomyelitis or even septic arthritis, which is not detected in the preoperative state. So a high degree of suspicion should be had for these patients. Femoral head collapse can be typically well identified using typical diagnostic modalities, X-ray, certainly at least from delineating collapse and pre-collapse. MRI and bone scan are better tests, although the reliability of these tests may be potentially compromised by the presence of internal hardware. Ultimately, the treatment algorithm for these patients is very similar. Ultimately, collapse versus non-collapse is the most important factor, which helps decide what treatment is most appropriate. Young versus elderly patients becomes a little bit more nuanced, particularly when it becomes physiological age versus expectations for many of these patients. Non-union, we know that non-union is a more rare problem, but is typically much more symptomatic than osteonecrosis. Osteonecrosis is actually relatively common if scrutinized, but may be asymptomatic. Non-union, depending on the cause of non-union, is important. Certainly if the non-union occurs because of mechanical fixation, but the biological environment is normal, then revision internal fixation with an attempt of compression plating or bone grafting is a very reasonable alternative. Some circumstances, I think at least, where arthroplasty would be a viable alternative for these patients are cases where the cause is clearly atrophic non-union or failure of biological environment. These patients are, in many cases, unlikely to be successful with revision internal fixation, and a more reliable procedure may be a revision arthroplasty. The age of the patient to some degree is important. Perhaps more important than age is expectations for these people. Certainly after arthroplasty, there are lifelong restrictions and limitations on what patients can do. So for a young patient who has certain expectations and needs, it would certainly be reasonable and highly defensible to consider revision internal fixation for these patients. Location of the fracture, the location of the non-union is also of some importance. Certainly the non-union as it relates to the proximity of the femoral head. The more proximal the non-union is, to some degree, the more likely these patients will undergo a uncomplicated total arthroplasty because of the proximal metaphysis, because the anatomy and integrity of the crater trochanter is normal. These patients often do reasonably well, and removal of internal fixation is typically unchallenging. So what about exclusive mechanical failure? For these patients, I think there's somewhat less controversy. It does depend to some degree on age. Certainly for younger patients, an attempted internal fixation, surely due to mechanical failure because of a poor implant or implant placement, deserve a chance at a revision and internal fixation. There are some nuances, however. Certainly femoral head viability and potentially even pre-existing degenerative arthritis are factors which are important in determining whether or not an arthroplasty versus a revision to internal fixation is the most reasonable option. Certainly we know that arthroplasty, although it may not be ideal in a young patient, is relatively reliable. So an attempted internal fixation has to have, I think, a high degree or likelihood of success. Certainly as least as high, if not higher, than arthroplasty in order to sell it in some degrees to a patient. Ultimately, although this is never the consideration, I'm sure, for a trauma surgeon, it's ideal not to compromise potential for a salvage total arthroplasty. A well-done internal fixation or an internal revision typically does not, but these may be considerations that a trauma surgeon has when planning for a patient's future. So infection, which is the bane of the existence, certainly of the total arthroplasty surgeon, we know that in the coming decades, this will certainly be the most important risk factor and the most common cause of failure of total arthroplasty. There are multiple factors common, again, to both trauma and arthroplasty, which are risk factors for failure and for periprosthetic joint infection for these patients. Open injury, wound problems, repeat INDs. Independent risk factors in arthroplasty, obesity, prior infection, immunosuppression, bacteremia, skin disorders, IV drug use. All of these are considered high risk pre-operative risk factors. Radiological risk factors include early implant loosening and osteolysis. This has been described by the Academy's clinical practice guidelines. This specifically pertains to early loosening of an implant, so a total hip or a total knee arthroplasty. At the same time, I feel at least that early implant loosening of internal fixation, a VHS, or a sliding hip screw, ultimately, if there isn't an obvious reason for failure, which can be explained mechanically, that infection should be considered and really considered present until ruled out definitively. So I think a high degree of suspicion should be had for all of these patients, and I certainly approach most of these patients with that degree of scrutiny. So ultimately, this is a busy slide that describes what the Academy recommends in terms of approaching patients with a high degree or moderate degree of suspicion preoperatively for infection. Ultimately, like I said, I approach all these patients with a high degree of suspicion, so everyone's screened for infection with an ESR and CRP. If the likelihood I feel is low, then ESR and CRP are adequate screening tools. Negative is unlikely for infection, but never zero. There's certainly a context for frozen sections if there's any intraoperative suspicion. Anyone who has a high degree of suspicion for infection gets a accumulation of ESR CRP as well as an aspirate. The aspiration allows you to analyze the synovial count, the differential, as well as culture. So that provides 5 metrics in combination with the ESR CRP. 3 of those 5, if positive, are suspicious or suggestive of infection. And this has been adopted by the Musculoskeletal Infection Society as well. Obviously, in arthroplasty, some degree have the luxury of time. We can work these patients up and optimize them. In the context of acute failed hardware, we don't often have that luxury, as you can imagine. So certainly, again, there may be a role for intraoperative frozen sections as well as stat intraoperative synovial fluid analysis to help guide decision making. So general principles of arthroplasty, we know that previous incisions, when available, should be used. Ultimately, the vasculature about the hip is different than that about the knee or the ankle, so new incisions, if necessary, certainly can be made with lesser risk of skin necrosis. Any incision that is utilized should be extensile enough that it can both remove hardware through the same incision and provide adequate exposure to allow for a robust reconstruction. If infection is definitively identified and arthroplasty is planned, although there isn't the abundance of literature on this, my recommendation, I think most arthroplasty surgeons would prefer a 2-stage protocol with debridement of all infected orthotic bone, implantation of an antibiotic impregnated spacer, whether they be mobile or static, intravenous antibiotics, monitoring of patients for both clinical improvement as well as inflammatory markers, an antibiotic window, reaspiration, and then definitive reimplantation should there be no evidence of residual infection. Leg length discrepancy is in some cases significant. Given the extent of modularity that exists today with total arthroplasty, most of these discrepancies can be overcome. Significant discrepancies may need multiple procedures for individual lengthening. Malunion can be a problem, certainly as it pertains to intertrochanteric fractures, and specifically as it pertains to the position of the greater trochanter. The trochanter, in many cases, or some cases, may overlap the canal. Trochanter may be malpositioned, resulting in a decrease in tension, which may compromise the stability of a total arthroplasty. In some cases, a trochanteric slide osteotomy is necessary in order for 1, access the canal, and 2, to retension the abductor to allow for adequate stability. Malunion of the metaphysis from the diaphysis is a very complicated problem. In some circumstances, may require staged osteotomies, simultaneous osteotomies, and certainly the availability of modular stems, which allow for independent baphyseal and metaphyseal fixation, are important in these circumstances. Maximization of fixation is important for all of these cases, I think, regardless of the location of the fixation failure. Secondary to disuse osteopenia or even subtle changes in anatomy typically preclude these patients from having successful fixation at the metaphyseal alone. So typically some degree of diaphyseal fixation is necessary, or even cemented fixation if, again, the biological environment has been compromised. Stress risers should be avoided by at least 2 cortical diameters, as we know, and stability should be optimized, certainly with a greater degree of certainty even than primary total arthroplasty. We know that amongst this population, dislocation is extremely common for a multitude of reasons. So maximization of stability through the variety of techniques and strategies we have should be achieved and should be confirmed on the operating room table prior to leaving. So specifically looking at failed femoral neck fractures, in the young person, we know that typically these fractures fail secondary to mechanical reasons. We know this partly because revision of these patients with internal fixation typically results in reasonable outcomes. The goal for most of these patients should be preservation of the native hip joint. A lot of this literature is based on poor success with total arthroplasty historically in patients who are less than 30. A lot of that literature may be flawed because cemented fixation was used and there were very high rates of aseptic loosening reported, up to 70% even at 10 years. And conventional bearing surface review, certainly in the early 80s when a lot of this literature became prevalent. So has anything changed really in the last 15 to 20 years? There have been some systematic reviews that have analyzed this. Closey's group looked at systematic review assessing total arthroplasty in patients less than 30 who had arthroplasty before 1988 and after 1998 when cement-less fixation became more prevalent. Although they found that the rate of radiological loosening was significantly less, patients were still clinically less than satisfied, and hip-related quality of life metrics were very low. Similarly, the group from Cleveland Clinic looked at activity levels and functional outcomes in young patients undergoing total arthroplasty. Again, the rate of loosening has approached 0, which is very similar, a 10-year outcome, a 10-year follow-up, I should say, in comparison to a total arthroplasty for primary degenerative arthritis. But again, patients are typically unsatisfied, young patients in particular. So I still think that in the absence of significant improvements in total arthroplasty, preservation of the native hip joint should still be the standard of care. We know that standard of care, historically at least, has been a valgus-producing osteotomy about the hip. As we know, the concept behind this is converting shear forces into compressive forces by changing a vertical fracture pattern into a horizontal fracture pattern. One of the advantages of this procedure may be the ability to increase leg length in shortened extremities. The disadvantages, certainly from an arthroplastic perspective, may include medialization of the diaphysis inadvertently, which can complicate the ability to apply a straight stem, as well as inadvertent shortening of the trochanter, which can inadvertently affect the abductor moment arm and potentially result in limbs and or instability. As I mentioned, the outcomes for failed femoral neck fractures through an intratrochanteric osteotomy are often high. Successful union has been reported anywhere between 70 and 86% in the literature, and cessation of head collapse is reported as very high, between 83 and 86%. In the elderly patient, I think there's somewhat less controversy, particularly in terms of the goals that we're trying to achieve: pain relief, early mobilization, minimization of complications, and ideally offering these patients a final arthroplasty or final option, whether that be internal fixation or arthroplasty, that will last the rest of their lives. So ultimately, if there is controversy, the question probably is, should we be fixing these in the first place? I think with recent literature, including some prospective randomized controlled trials, that question is certainly up for debate. Total arthroplasty, in this study out of Sweden, demonstrated a 17-year follow-up improves clinical outcomes as well as improved functional outcomes for the total arthroplasty group in comparison to the internal fixation group. More importantly, potentially, in the internal fixation group, again, a 17-year follow-up, 39% of these patients in the internal fixation group required a major reoperation, as opposed to 9% in the total arthroplasty group. And most of these reoperations were conversions to total arthroplasties, and most of those happening within a short time period. So the question could be, why not try to fix them, and then if they fail, convert them to a total arthroplasty? The question was asked by this group out of the UK. They did a retrospective matched case cohort series looking at patients who either underwent total arthroplasty for acute femoral neck fractures, which are displaced, or underwent a salvage arthroplasty for failed internal fixation, 107 patients in each group. Ultimately, they found that in the group which was salvaged, there was a significantly increased rate of both superficial and deep surgical site infections, 12 as opposed to 3. And more worrisome, there were 21 dislocations in the salvage group in comparison to 9 with acute total arthroplasty group. Decreased functional outcomes were also seen, as well as implant survivorship. So the reasons for this might be multifactorial, certainly, but ultimately, when matching these groups as well as they could, the salvage arthroplasty group potentially may have compromised the successful acute total arthroplasty for these patients. We know that there are two major options, hemiarthroplasty versus total arthroplasty. The technical considerations are relatively similar for both of these patients groups. Surgical approach, I think, is surgeon's choice. Again, hardware removal should be easier and should be accessible through whatever surgical incision is chosen. It's important to dislocate prior to hardware removal in order to avoid the likelihood of fracture or propagation to screw sites. Osteoporosis is 100% essentially in all of these patients, so broaching should be extremely careful. Reaming of total arthroplasty is considered should be very careful. Currently, likely the standard of care for these patients, at least on the femoral side, is the cemented arthroplasty. On the acetabular side, press fit is a reasonable option, knowing that a high rate of peripatetic fractures have been reported in some patients, particularly with elliptical cups, and when placing a cup which is larger than 2 millimeters, that is prepared for. Larger femoral heads certainly should be considered. We know that instability is very high in these patients, even if it comes at a compromise the thickness of the polyethylene. The advantages of hemiarthroplasty certainly may include shorter operative time. Less blood loss has been historically reported in literature, although this paradigm may be changing now with the increased use of tranexamic acid. The total arthroplasty literature, in several recent studies, the incidence of transfusion is approaching 0% after the use of tranexamic acid, so this may become less of a relevant issue. The advantage may be increased in stability, given the large head sizes which are available, given that the acetabulous component does not need to be considered. The major indications, I think, at this point really are cognitive and neuromuscular disorders, which may preclude the use of hip precautions or may predispose a patient to instability due to muscular imbalances. Surgeon familiarity certainly is a consideration. Total arthroplasty in this patient population group is not as straightforward as primary degenerative arthritis, and certainly if the surgeon is prepared to perform this operation, they have to be prepared to deal with any of the complications which may occur intraoperatively or postoperatively. The advantages of total arthroplasty at this point, I think, are quite clear. Most studies in the literature that have looked at this demonstrate consistently improved pain and improved functional outcomes in comparison to hemiarthroplasty, and in some cases compared to internal fixation. Increased implant longevity may be an important factor, particularly for younger patients, and then subsequently decreased revision rates in comparison to hemiarthroplasties, and particularly bipolars, which have a poor quality polyethylene and may have a high rate of femoral loosening. The historical indications for this problem were acetabular-sided arthritis with pre-existing hip pain. Again, this paradigm may be changing given the recent literature, the predominance of literature that's been published. Community ambulators certainly, again, historically have been considered more likely for this patient. Low demand patients still certainly may best benefit from a hemiarthroplasty. The literature, what does it show? This is a recent meta-analysis by Mobandari's group looking at 8 randomized controlled trials, including approximately 1,000 patients. Essentially, all metrics that they measured, hip scores, the pain score, all of the WOMAC, the overall WOMAC score, as well as hip-related quality of life scores, all demonstrated statistically significant improvements with total arthroplasty in comparison to hemiarthroplasty. One major disadvantage, again, continued to be dislocation in this group, although this trial also included patients that have smaller femoral head sizes and potentially even before robust posterior capsular repairs were known to be important. The dislocation rate in more recent studies has shown to be more equitable, and with the popularization of tripolar constructs or dual mobility type constructs, the rate of instability is very, very low, even in this high-risk population.
All right. Just want to echo my colleague's sentiment at the beginning of this talk. Thanks for coming out. It's really a pleasure to be able to speak with you this morning about this topic, which is near and dear to my heart, involving both trauma and arthroplasty. But moving forward, we've sort of talked about how these cases are a little bit complicated. It's not the classic, paint by number arthroplasty cases that we often get teased about, every knee being the same and every hip being the same. And when we look at the literature, one of the big questions is, are these conversion cases being done by trauma surgeons? Are they being done by arthroplasty surgeons? Who are they being done by? Why do people think it's so hard? But I would say, don't just take our word for it. Here's a group, Rothman does a lot of arthroplasty, and they looked at their own series in expert hands, converting failed femoral neck fixation and intertroch fixation to total hips, and they had a close to 10% complication rate, which is much higher than their quoted elective complication rate, obviously, and a 7% reoperation rate, which is also very high for their group. They noted also in this group, comparing the femoral necks to the intertroch fracture revisions, that intertroch conversions were much more difficult. So that kind of segues into the next topic here, where we're going to be looking at total hip arthroplasty in the setting of intertroch fractures. But if you look, this is a table from their paper, and dislocation rates range anywhere between 0 and 22% in these conversion procedures, and the reoperation rate also is anywhere between 8 and 18%. So let's look at total hip arthroplasty in the setting of intertroch fractures. So we commonly see it indicated in failed fixation of intertroch fractures in the elderly. It's less commonly performed acutely for intertroch fractures. Let's look at a case here. This is a case that I did during my fellowship. This is a 61-year-old female that presents after a mechanical ground level fall. She has a history of significant alcohol use and hip pain, and she presents with these x-rays. So I'm going to ask one of the residents maybe to sort of tell me what they think here. Dr. Hug. Yeah. What else do you notice about her hip? Yeah. What about her femoral head? Right. I think those were all good points. So she kind of has, I would say this is probably sort of a reverse obliquity type intertroch fracture, some subtroch anterior extension. She has obvious cystic changes on both sides of her hip joint. But the surgeon on call went ahead and decided to fix this with a cephalomedullary nail. But technically, they did a good job with the bone stock they had available. And you can kind of guess where this is going to go. The fracture ended up healing. The problem is the head really didn't support the metallic implant. It cut right through it a couple months after she was fixed. So now we have to help this lady who is no longer able to put weight through her right lower extremity. So when we're thinking of how to plan for these cases, we have to kind of bring a bigger toolbox. It's not the standard total hip. So there's a few things to address. So maybe I'd ask Dr. Warner what she thinks in terms of options for stems, sockets, and maybe any adjunctive procedures at the time of hip arthroplasty of patient. And what about stem fixation options? Could you use like a metaphyseal engaging stem, diaphyseal engaging stem? I think those are all good points. Obviously the metathesis here has been violated by the cephalomedullary screws. You're not going to have reliable fixation there. Also, given our history of AVN, I think the bone quality in general is going to be poor. And then I think you want to have augments available is not a bad idea, but certainly some bone graft available too to help with some of the cystic changes you see on the acetabular side of the joint. And then one thing that we're going to touch on a little bit more later is stability in these patients. So after a cephalomedullary nail is placed, commonly the abductor insertion on the trochanter is bleeding away, and these patients have a compromise of their hip stability. So you want to have other options such as a dual mobility type construct or even a constrained liner sometimes to help with your stability. She has a little bit of troch overhang here based on the way her fracture is healed. So in those patients, it's good to have a burr available too to kind of make sure that you can get through some of the sclerotic bone with your broach and access the intramedullary canal. So she underwent diaphyseal engaging stem placement and a dual mobility type construct with bone grafting of her acetabular defects, and she did very well. These are 3-month follow-up X-rays. But how do these patients do in general? This is a very classic article here from the Mayo Clinic. Heidekewicz and Berry looked at 60 patients done between 85 and 97 with a mean follow-up of 5 years. 44 patients that were available for analysis. 40 were able to ambulate. They had 2 revisions. We only had 1 patient who had 2 dislocations. Now, I think a lot of the low complication rate here is due to high incidence of cemented stem fixation. So this decreases your risk of intraoperative fracture substantially in these patients. But overall, encouraging results. So that one was the first one that I showed is kind of easy because the troch's already healed. So bigger problems arise when you have a troch fracture that hasn't healed already. So this is a 83-year-old gentleman that presents 2 weeks after his intertroch fracture was fixed, and he sustained a ground level fall. He also happens to enjoy drinking alcoholic beverages. And these were his presenting films. He underwent fixation with a helical blade type cephalomedullary device, and after his ground level fall, he ends up with this. So maybe I asked Dr. Gundel to tell me what he thinks about the X-ray and what he would want to do and have available for this case. Yeah, so I think options here include I would probably take revision fixation off the table for this gentleman just because he's 83 and his bone looks really horrible. Additionally, in terms of the arthroplasty options, I think you're right. Diaphyseal stem's important. You want to bypass the distal interlocking screw there to prevent a stress riser. I think that's important. And then your options really are, either a proximal femoral replacement for this gentleman, depending on the soft tissue attachment left on the trochanter, and a revision with a either a modular or diaphyseal engaging stem and a cabling that trochanteric segment to your construct. So what we ended up doing was preparing the distal aspect of the femur with a diaphyseal engaging stem. You can see we have a cerclage cable around that, which we place prophylactically before we start reading to prevent propagation of the fracture. I think that's a very important technical pearl. You want to remember to do that so that you don't end up with a long spiral diaphyseal fracture when you're preparing these osteoporotic patients. And then what we were able to do is once we had the stem down, cable the trochanteric fragment back to the patient, in the construct that we had distally. And so these are his final x-rays. And unfortunately, this patient actually developed a periprosthetic infection. He had a lot of risk factors for that, including poor protoplasm, 2 operations within a 2-week period of time. And he ended up getting explanted and as a spacer and now. But it's important when you think about intertrochanteric fractures to remember the spectrum of stability. And this is an important slide, I think, not just for trauma surgeons, but also for arthroplasty surgeons who take trauma call, and anyone really that takes trauma call. We like to think, intramedullary nails can take care of most problems, almost all problems as it relates to intertrochanteric fractures. But I think the sliding hip screws are also very good devices to use in more stable fracture patterns. And, so in the absence of some of these radiographic findings that may indicate a more unstable fracture pattern, we want to think about using DHSs or sliding hip screws because there's been data to support that revision of a sliding hip screw has a much lower complication rate when compared to revision of an intramedullary nail. So this study, which was a multi-center study, showed a 42% complication rate when intramedullary nails were revised compared to a 12% complication rate when DHSs were used. And I think a lot of that, based on what the authors are talking about, is the result of damage to your trochanter, damage to your abductor insertion, resulted in instability. I think there's some selection bias, obviously, in this study because the fractures that we're using intramedullary nails on are inherently more comminuted and more unstable, and potentially the bone is worse. But it's really important to think about if you have an intertroch fracture that would be amenable to DHS fixation. I think it's something that you should favor. So we talked about sort of the conversion of a healed intertroch fracture. We've talked about more acute in the setting of a non-union or a periprosthetic fracture around a nail. What about acutely? When is it indicated that patients should undergo acute total hip arthroplasty in the setting of intertroch fractures? Some people think never. Some people think if there's pre-existing osteoarthritis or AVN, history of radiation, anything that would compromise fracture union. Also, some inflammatory arthritis patients may benefit from acute total hip arthroplasty. So here's a study that looked at IT fractures treated in rheumatoid arthritis patients, and they had a failure of fixation in this series of close to 1/4 of patients had failure. Now, I think that it's unfair to say that all these patients would have benefited from arthroplasty because some of these failures were a result of infection, which obviously wouldn't be any better for a hip replacement. But certainly, there is a component here to think about in patients that have inflammatory arthritis that present with intertroch fractures. You may want to consider acute arthroplasty. Here's another study out of Belgium. They looked at 37 patients treated with endoprosthetic replacement. They compared this to 42 patients treated with a fixed angle plate, and they found that replacement was associated with better rehab, decreased pulmonary complications, decreased bed sores, and good functional outcomes. And again, this is not compared to more conventional means of fixation, such as IM nails. This was, however, studied. This is an article from, I believe, 2004 in JVJS, and they looked at intramedullary nail fixation versus uncemented calcar replacing hemiarthroplasty, and they found no difference in Harris hip scores or functional results, but they did find increased operative time, increased blood loss, increased cost, and increased 3-year mortality in the replacement group. So I certainly don't think we should be giving up internal fixation for these patients, especially with modern forms of fixation, which I think outperform the majority of patients that present with these fractures. So what about extenuating circumstances? So this is a case I did towards the end of my fellowship. This is an 86-year-old male that presented with an intertrochanteric fracture. He had significant pre-existing arthritis and essentially an autofused hip. He had a previous skiffy, which was fixed with some Knowles pins that you can see were buried. And this is a gentleman, I think, that meets criteria for acute arthroplasty in the setting of intertrope fracture for a number of reasons. One, he had a particularly painful hip to start. Two, it's very hard to move the proximal segment when you have an autofused hip, so it makes reduction of this fracture particularly challenging. And then even with hardware in place, the most likely spot that the leg is going to move is through the fracture site and not through his fused hip joint. So this is one that was particularly challenging and required a pretty big toolbox and some sort of advanced arthroplasty surgical techniques, including an in situ neck cut, placement of a modular stem, and then obviously the fixation of the intertrope fracture. I'm not going to belabor that. But these are just a summary of key technical pearls that I think are shared when dealing with failed femoral neck fixation and intertrope fixation. You want to have many stem options available for the acetabular side of things. You want to have different levels of constraint, especially if you're revising intramedullary nail, given their high rate of reported dislocation following conversion procedures. You want to make sure you have bone graft available and avoid some of the other risk factors for intraoperative fractures, such as broaching through sclerotic bone. So I would just submit that for your review, and that's online. We're going to move on to our final topic, which is total hip arthroplasty in the setting of acetabular fractures. So when is total hip arthroplasty a player for these patients? So obviously failure of fixation. And then I think also it's worth consideration in acetabular fracture types that have not historically demonstrated much success, either acutely or subacutely after a period of benign neglect. And then certainly if you have combined acetabular and femoral head or neck fractures, these patients don't tend to do well, or pre-existing osteoarthritis or inflammatory arthritis. So I'll touch on this briefly. Goals of acetabular fixation, obviously to restore anatomic joint surfaces, maintain the femoral head reduced underneath the acetabular dome, restore hip biomechanics. When these cannot be reliably achieved, I think arthroplasty should enter the conversation. So acetabular fracture fixation, as you guys well know from your time at Harvard, it's a high stakes game. So you get within 2 millimeters, patients tend to do pretty well. We have a 13% chance of post-traumatic arthritis. If you're greater than 2 millimeters, that essentially triples that risk. So big time football. And then there's certain fracture patterns, obviously, that are bad players. This is from Anglin's article looking at impaction of the dome and the medial wall of the acetabulum, which was a predictor of failure in 100% of patients in his series. So this is a paper by Herscovici out of Tampa, and he looked at combined fixation and total hip arthroplasty in some of these patients that have bad fracture patterns that historically have done poorly with standard fixation techniques. And he looked at 22 patients with an average follow-up of close to 3 years, and following his surgeries, this combined fixation and arthroplasty, the patients achieved a Harris-Hip score of about 76. Notably, 6 patients did have post-operative dislocations and 5 required revision for osteolysis or instability. So here's a case that I did with Dr. Heidekewicz during my trauma fellowship in a patient that had medial wall, essentially a bicolumnar fracture with medial wall impaction. And you can see there on the CT, he also had a gold sign there on the coronal slice. You can see 3D renderings there. Essentially what we did was plate his posterior column to give us a buttress to work with, and we placed the total hip arthroplasty, and that patient did pretty well. What about subacutely? This is a paper by our very own Dr. Bella Barba, and he looked at 30 patients that had total hip arthroplasty performed on an average of 37 months following an acetabular fracture. Half of the patients that he looked at had undergone fixation, half had undergone conservative management. And they compared these patients to 204 controls treated for non-traumatic osteoarthritis. And the survivorship and the Harris hip scores were comparable to this group, essentially statistically indifferent. And notably, what I find interesting is that in this group that's converted, they had no dislocations or infections. Begs the question, maybe we should try and fix everything if they do better when we convert them. So that may be something worth combining our efforts at Northwest and Harborview and maybe looking at a study to do that. Here's a couple cases that I've had the opportunity to be involved in since coming to Seattle. This is a patient who sustained a significant injury while skiing. He had bilateral injuries. He had a femoral neck fracture on the left, which went on to non-unite and required a pulse osteotomy. You can see there. And then he had an acetabular fracture, a subtroch fracture, and distally shaft fracture of his femur. So unfortunately, despite excellent fixation and anatomic reduction of his acetabular fracture, he developed AVN of the femur, and this was revised. Actually, all the hardware in this case was left in place. We were able to ream up to the lag screw and had good coverage of our acetabular component. His nail was removed and replaced the diaphyseal engaging stem, bypassing his previous subtrochanteric fracture. We did lengthen him a little on this side as he was short preoperatively due, I think, to some shortening of the leg through his femoral shaft fracture, as well as lengthening of the contralateral side through the pulse osteotomy. So he's very pleased with the length we were able to get him. Here's another case I was involved in yesterday with Dr. Clavino. This is a patient that was treated for a bad posterior column, posterior wall acetabular fracture. You can see postoperatively excellent reduction was achieved. Despite this, the patient underwent a mechanical failure with subsequent dislocation of his hip, and we had the opportunity to tag team this yesterday, and you can see the hip center was medialized and also moved proximally, secondary to some of the bone loss that occurred due to his non-union. But despite that, we were able to get away with only needing to remove a couple screws and get a nice hip in for him. So the things that you want to have available for these cases, obviously, are metal cutting burrs. You want to make sure you have bone graft available. This patient required a dual mobility construct given his history of chronic dislocation. You want to make sure you have options, including constrained liners, dual mobility bearing surfaces, and other things to maximize your hip stability. So these are challenging cases. They're fun cases. And certainly it's been a pleasure starting here and having our colleagues at Harborview to work with. And thanks for the opportunity to give this lecture this morning. I hope you found it educational and thought-provoking. So thanks a lot.